So let me welcome you to the second ISE webinar. Should say good morning, good afternoon, or depending wherever you are. And it's my pleasure to co-host a meeting with Bülent Görnek from Turkey. So first of all, again, it's my pleasure to introduce the first speaker, Dr. Andres Enriquez, who's Assistant Professor at Queen's University in Kingston, cardiac electrophysiologist with a special interest in ablation of complex arrhythmias. And he's going to be talking to us today about PVCs. Let's just leave it as PVCs, and then he can have a complete open field to talk about. So look forward to listening to what you've got to say. Thank you.
Okay, thanks very much. Thanks very much, Bülent and Peter, for the invitation. So I'm going to talk today about how to use the ECG to predict the site of origin of PVCs and other ventricular arrhythmias. I know Peter is going to correct me if I say any nonsense. So the ECG is the initial mapping tool we have to predict the site of origin of ventricular arrhythmias, and is very accurate in focal arrhythmias in patients without structural heart disease, but is less reliable in patients with cardiomyopathy and myocardial scars, right? So for us, invasive EPs, it's very important for pre-procedural planning when we're considering ablation, to counsel patients about the risk of the procedure, and also to select the right tool. As we know, the ECG has some limitations, and there may be variations due to factors such as body habitus, lead placement, rotation of the heart, etc. So to interpret the ECG, it's important to understand the position of the heart within the chest. And classical anatomy textbooks describe the heart in the Valentine position, as we see here, in which the heart stands on its apex with some rightward rotation. But we know that this description is correct, and this is the attitudinal or anatomical orientation of the heart within the chest. So as we see, the RV is anterior and to the right of the left ventricle. The base of the LV is posterior, and the apex is anterior and to the left. So several ECG features are useful for PVC localization in our clinical practice. So first we have the QRS axis, which has a vertical dimension, which is best reflected by the inferior limb. So a positive 2 and 3 suggests an origin in the superior aspect of the ventricle. So, well, with the outflow tracts here and the superior aspect of the mitral and tricuspid valve. And a negative 2 and 3 suggests an origin in the inferior aspect of the ventricles. And we have a horizontal dimension best reflected by lead 1. So a positive lead 1 suggests an origin in the right side of the midline, while the opposite is when lead 1 is negative. Second, we have the right band, the bundle branch block pattern. So PVCs with a right bundle pattern arise in the left ventricle. PVCs with a left bundle pattern arise in the RV, in the right ventricle, or in the septum. Third, we have QRS duration. So PVCs from the septum usually have narrower QRS than PVCs from the free wall of both ventricles. And finally, a precordial transition. So in PVCs with right bundle pattern, the transition gets later as the site of origin moves from apex to base. And in PVCs with a left bundle pattern, the transition gets later as the site of origin moves from the septum to the RV free wall. So we follow a stepwise approach for localizing PVCs. And the first step is to look at the superior inferior axis reflected by these inferior leads. So if the axis is inferior, we're gonna be here in the outflow tract or the superior aspect of the mitral and tricuspid valves. If the axis is superior, we're going to be in the inferior aspect of the ventricles. And then we look at lead 1 and the bundle branch block pattern to determine if the origin is in the right ventricle or the left ventricle. And once we regionalize the site of origin to one of these 4 quadrants, we look at other ECG features to predict the likely site of origin. And these are going to include transition, QRS duration, and specific morphology in certain leads. So I like this slide because it shows the value of the frontal axis and transition for localizing PVCs. And here we can see The RVUT is actually, anterior and leftward relative to the LVUT. Note that the anterior aspect of the RVUT is actually a leftward structure, while the right coronary cusp of the aortic root is actually on the right side of the midline. So if lead 1 is positive, the origin is going to be on this side, and here we have the posterior RVUT, the right cusp, and the tricuspid valve. If lead 1 is negative, we're going to be on the left side of the midline, and here we have the anterior RVUT and all the LVUT structures with exception of the right cusp. So second, we look at transition, and as you see here, the free wall of the RVUT is the most anterior structure, and as we move toward the mitral annulus, the transition gets progressively earlier, and we transition from a left bundle pattern to a right bundle pattern. So when transition occurs at before or later, the origin is going to be in the RVUT. When transition is at V2 or earlier, usually the origin is going to be in the LVUT. And things are more difficult when transition is at V3, because the origin may be here in the septal RVUT, but also in the right cusp. So different algorithms have been proposed to differentiate RVUT versus LVUT origin in these cases. And this is the one I like. I usually use this one from UPenn, which compares the transition during PVC and sinus rhythm. So when the PVC transition occurs later than sinus rhythm, the origin is going to be in the RVUT with high specificity. When transition occurs earlier than sinus rhythm, we measure the V2 transition ratio, which is the percentile R wave during PVC divided by the percentage R wave during sinus rhythm. And if this number is more than 0.6, that's going to predict an LVUT origin. So as I mentioned, some morphological features may suggest a particular site of origin. And as we see here, for example, in the RVUT, we know that PVCs from the RVUT free wall usually have later transition compared to those PVCs from the septum. These are also wider, usually over 140 milliseconds, and have frequent notching in the inferior leads, as we see here. Parahesian PVCs that we have here are also very characteristics. They have a narrow QRS, usually with lead 2 taller than lead 3, and also they have a positive AVL, something that we don't see in outflow tract PVCs. In the LVUT, on the other side, for example, PVCs from the left cusp have early transition at V1 or V2, often with this multiphasic pattern. In V1, PVCs from the right-left cusp junction usually have this QS pattern in V1 with a little notch here in the downward deflection. PVCs from the mitral annulus usually have positive concordance with a monophasic R wave in V1. And a particularly challenging arrhythmia for us are PVCs from the left ventricular summit, which is the epicardial aspect of the LVUT. So these may have a left bundle or right bundle pattern, depending if they're from the septal or the lateral aspect of the summit, and usually have some characteristics suggesting an epicardial origin, such as this slur onset of the QRS or pseudo delta wave, and also a QS pattern in lead 1. So we're going to look at some examples. So this is a patient in his 60s that presented here to the hospital with this incessant VT. So as you see here, the VT has inferior axis, so it's positive in 2 and 3. So we're in the superior aspect of the ventricles, and lead 1 is predominantly positive, which points to the right side of the midline. Finally, transition is relatively late. As we see here, it occurs at before, which is consistent with an RVUT origin. And you can even be more specific and say that probably from the septal aspect, because the QRS is not too wide, and also we don't have these notches, we don't have notches in the inferior leads. So we brought this patient to the lab. So you can tell that he really needed the ablation. That's the baseline ECG. And we created this activation map with this multipolar catheter called HD grid. So here we have the RV apex, the tricuspid valve, and the pulmonary artery. And in this map, white and red means early activation. So we start seeing how, the map starts to delineate this site of early activation here. So this is the final activation map. So you can see that the site of origin is the posterior and septal RVOT, as we predicted. And we can also convert this map into a video or propagation map where we can see the activation spreading from this region to the rest of the heart. So ablation here eliminated the VT. Patient went home without VT, and we were able to stop the antiarrhythmic medications. So we have another example. So this was a young patient, a young student, 20 something, with these very frequent PVCs. And here we see that PVCs also have an inferior axis of positive 2 and 3, but in this case, lead 1 is negative. So we're talking about this quadrant here. And we see that the PVCs have positive precordial concordance. There is a monophasic R wave in B1 and also a small terminal S wave in B6. All these characteristics suggesting an origin from the superior aspect of the mitral annulus. So this is the activation map of this second patient. So here you can see that this is the mitral annulus here. This is the aortic root. So earliest activation was mapped to the superior aspect of the mitral annulus. You can see in the electrograms that, activation here precedes the QRS by 30 milliseconds. And actually, if we pace here, the pace morphology is very similar to the PVC. So we started ablating at this spot, and here you see PVCs, and after 7 seconds, the PVCs are gone, right? Yeah. So this patient went home with no PVCs, and a few weeks later, the patient stopped by my office to show me this nice tattoo that he got because he was feeling so great.
Don't tell mama's tattoos.
So this is another example. So this here we have another PVC with inferior axis, so positive 2 and 3. Lead 1 is positive, also 2 is more positive than 3. So all these suggests, all these points to the right side of the midline. So we're talking about this area here. So now if you look at the QRS, it's quite narrow and also very similar to the sinus QRS. So this is a parahesian PVC. You can also see that AVL is positive, something that we don't see in outflow tract PVCs. And the reason is because the parahesian region is lower and to the right relative to the outflow tract. So AVL is a high and left lateral lead, so the vector is going to be directed toward that lead. So again, this is the electroanatomic map in this patient. So this is the right ventricle seen from the septal side. Here, his region is marked with these yellow dots, and you can see that the ablation site was a few millimeters away from his region. You can see here in intracardiac echo as well how the tip of our catheter is just underneath the septal leaflet of the tricuspid valve. So ablation here eliminated the PVC. So this is another example. So here we have another PVC, in this case with superior axis, so 2 and 3 are negative, and with a right bundle pattern, so positive B1. So this has to be an inferior structure in the left ventricle, so this quadrant here. And as you see, there are no many structures that can produce this pattern. So here we have the inferior mitral annulus, we have the posteromedial papillary muscle, and the left posterior fascicle in the septum. So how can differentiate PVCs from these structures? So usually mitral annular PVCs, we know that these are going to have no transition, so there is positive concordance. Fascicular arrhythmias are usually quite narrow, and they exhibit this RS, R prime pattern in B1 mimicking a typical right bundle pattern. Often they also have small Q waves in lateral leads. Papillary muscle arrhythmias on the other side are going to have a QR, RR prime or RS R prime in B1. So here we have, that pattern in B1. and usually there's no Q waves in the lateral lead. So these characteristics suggest an origin from the posteromedial papillary muscle. And let's see if that's true. So that's there you can see what the EP study showed. So this is the left ventricle on intracardiac echo with the posteromedial papillary muscle, and you can see the catheter with the site of ablation. So this hyperechogenic region shows the lesion formation there, and that's where the PVC was eliminated. Here the same on electron-atomic map. And I have a last example here. So here we have also another PVC with superior axis, so -2 and 3, but in this case with a left bundle pattern. So this pattern can be produced, as we see here, by PVCs from the moderator band or the right ventricular papillary muscle, from the cardiac cracks, which is this epicardial region here, or from the inferior tricuspid annulus. So again, how can we differentiate these arrhythmias? So PVCs from the moderator band or right ventricular papillary muscle usually have a late transition, always later than sinus rhythm, and usually at V5 or V6, which is our case. You know, in our case, we have transition at V6. PVCs from the cardiac cracks are very characteristic. They have early transition, usually at V2. They have a QS pattern in inferior leads and also a pseudo delta wave suggesting their epicardial origin. On the other side, tricuspid valve arrhythmias have variable transition depending if they're more septal or more lateral, so V2 or V3 from the septal annulus, V4 or V5 from the lateral annulus. We often see a QS pattern in V1 for septal PVCs or an RS pattern in V1 from the lateral tricuspid annulus. These septal arrhythmias also, of course, are narrower. So this is what the EP study shows. So this is another map of the right ventricle with the pulmonic valve and the tricuspid valve. And here you have the moderator band, which is a muscular trabeculation that extends from the septum to the free wall of the RV and provides support to the anterior papillary muscle, which is this structure here. So you can see the site of ablation marked with red dots. And also here you have the moderator band on intracardiac echo, and you can see where the ablation catheter was in contact with the tissue, and an ablation here eliminated this particular PVC. Here on intracardiac electrograms, you can see that activation is earlier here relative to the QRS. And also when we pace here, the pace morphology is identical or very similar to the clinical PVC. So in summary, understanding the heart anatomy and anatomical relationships is crucial to interpret the ECG for PVC localization. We have to use an organized and stepwise approach. And the idea is to regionalize the site of origin to concentrate mapping efforts to a limited region or chamber. And if we fail, we always go back to the anatomy for reasons of failure. So is the site of origin epicardial or intramural? Did the site of exit, did the exit change maybe because of our first lesions? Can we target that site from a neighbor structure, etc.? Thanks very much.
Well, thank you very much indeed for a very, very interesting talk and for keeping so well to time. Could I ask one very quick question? You haven't referred in any way, say, to inverse modeling to locate the potential site. You're quite happy to avoid all of that and just rely on your own expertise to locate the PVC site, the PVCs, from what I'm understanding. In other words, do you think it's a waste of time to do any kind of inverse mapping to find a PVC?
Yeah, we usually don't do that. Yeah, we take a general look, on the ECG to basically, for us it's important to know if this is from the left ventricle or the right ventricle. We like to have some clues to see, you know, if a PVC is epicardial, because in that case, of course, the risk, you know, for the risk of the procedure are higher, and also we need different tools. So we typically use, you know, in our clinical practice, we like to have, you know, a general idea where it's coming from, basically for that purpose. So we know we're gonna know for sure. We know once we place catheters in the heart, we're gonna have the final answer. But you know, that's the purpose for us, you know, of looking at the ECG. So basically a general idea where this is coming from. And sometimes we're wrong because, you know, sometimes the heart is different, you know, in every person. So sometimes, you know, I would say probably 10 or 20% of cases, we don't get it right from just the analysis of the ECG, and that's okay, you know.
Okay. Well, I'd like to see if there are some questions here. I've got one. I'm not sure if it's from Adrian. Oh, it's just moved. It says, can you recognize a specific pattern of intramural PVC?
Yeah, so that, you know, that's an interesting question. So intramural PVC are probably one of the most challenging arrhythmia for us because, you know, these are arrhythmias that are not coming from the endocardium or the epicardium, but from the intramyocardium. So access, you know, is limited for our catheters, and actually in these cases we have to use, you know, special techniques to get rid of these PVC, some of them investigational. So there's no, you know, specific ECG criteria that tell us or suggest to us that, you know, a PVC is intramural. And actually we're looking at that, you know, we're collecting, and probably that's why, you know, Adrian is asking me, because we are collecting a series of intramural PVCs from a multi-center, you know, effort. And we're going to start looking at, you know, some patterns that may suggest, you know, this origin, because these are, you know, particularly challenging cases in the lab.
Thank you. Another question here from Dr. Demirtas. I can't see on the screen to allow him to ask it, but it says, how is your treatment approach for patients with PVC after COVID-19?
Well, that's a good question. So we know that, you know, COVID-19 may have, you know, what may cause, you know, a cardiac involvement, you know, and may cause, you know, some cardiac arrhythmias. So probably we don't know the answer yet for that. I would approach this patient, you know, in a similar way to other, you know, patients, you know, without history of COVID, maybe with a prior history of viral myocarditis. Of course, I think probably, you know, after a recent COVID infection, I would wait to see, you know, if this is a transient phenomenon. So there are many questions for which we don't have answers. But generally, I would say that probably the approach is, you know, similar to a patient with other type of, you know, viral involvement of the heart.
Okay, still time. Kel has asked a question. Would you like to unmute, Kel, and ask your own question? Or can you hear me?
Yeah, I wonder if there are PVCs with narrow QRS.
Yeah, that's a good question. So yeah, so we have PVCs with a QRS narrower than 120 milliseconds. So we're thinking that suggests, you know, simultaneous rather than sequential activation of the RV and the LV. So that may happen in you know, septal ventricular arrhythmia. So parahesian ventricular arrhythmia sometimes may have a pretty narrow QRS, often less than 120 milliseconds. So arrhythmia is very close to his region. And on the left side, also fascicular arrhythmias. We know that fascicular VT may be narrower than 120 milliseconds. Fascicular PVCs is the same concept.
Do you have ECG examples of epicardial PVC?
These are usually wider, you know, than endocardial PVCs. You have this slur onset, you know, at the beginning. So usually, or pseudo delta wave, as you can call it. And usually, you know, you're gonna have, if these are from the anterolateral LV, you're gonna have this QS pattern in V1. sorry, in lead 1. When a PVC comes from the endocardium, you should expect a little R wave at the beginning, showing the, endo to epi activation. But when the PVC originates in the epicardium, you're gonna have a plain QS in that lead. Same concept when an arrhythmia is from the crux region, which is the epicardial part of the inferior, junction between the RV or LV, you're going to have a QS pattern in the inferior leads because there's no endo to epi depolarization.
Let me thank Dr. Enriquez for a very enlightening talk. I found that really very, very interesting. So thank you very much indeed. And I'll hand over to Bulent to introduce our next speaker.
Hello to everybody. We have one more question, but if we will have time, we will go back to Andres after Emanuele's talks. Now it's my pleasure to invite Emanuele Locati. She's from Italy, and her topic is drug-induced proarrhythmia. Please, Emanuele.
Good afternoon to all of you. It's a pleasure to be here on the net. It's always, a good opportunity, and I hope I will give you some interesting information and maybe some timely information on the problem of drug-induced proarrhythmias. What is the definition is an effect that you don't expect, of course, that instead of healing your arrhythmias, aggravate or induce new arrhythmias. And also the induction of arrhythmia by drugs that are administered for non-arrhythmic diseases. It is, so keeping in mind these two different scenarios, it is also to be underlined that there is a possibility of addictive effects among drugs, and this is really part of the problem, and with drugs and metabolic condition. I will try to cover, because the field is enormous, of course, but I will try to focus a few points. One is that, of course, that interacts a lot with the metabolic condition, and the other is that there are some genetic predisposition, and this is really going to be the matter for the future. And also there is a well-known factor, gender effect. So this is more frequent in female. So this is just a definition I gave you before as paradoxical effect of drugs given for arrhythmias, aggravating arrhythmias, or non-cardiac drugs administered for non-arrhythmic diseases and giving arrhythmia nonetheless. Possibility of addictive effect between drugs and metabolic condition, hypokalemia, or even some food, and we'll see alcohol, etc. Possibility of a genetic predisposition and increased risk for female gender. And this is a picture that really summarizes part of this, female and some present condition in the heart, like in this case, it's a blocked atrial arrhythmia giving this pattern and favoring the onset of the drug. We know that the list of drugs is basically never ending. There is several sites, I would say, that really summarize this, just to give you the idea that there are many antiarrhythmic drugs involved, but also many non-cardiac medication, antihistaminic, antipsychotic, depressant, neuroleptic, opiate, anesthetic, antibiotics, anti-malaria, antiprotozoal, antifungal, antimotility agents, etc. So this means that you may be unaware of the therapy of your patient. This is the example of a site where you can really have a very comprehensive view of all these interaction of drugs and effects. And I now want to go to the basis of the story. And I unfortunately have to give a few slides on what's going on at really the cardiac cellular level. Of course, everybody knows there is depolarization and repolarization, and this is ruled by channels that favor depolarization. Allow repolarization are in red. Basically, they are sodium and and calcium inward currents, and repolarization, as you know, are mainly potassium currents, outward potassium currents that activate in different phase of the repolarization. And this is important to be kept in mind because in fact drugs act at different level. And this is go to the original classification of drug, which is still useful to, because I mean, there are sodium channel drugs, and between the sodium channel drugs, there are different variety, 3 subclasses, and they have in fact a different possibility of proarrhythmic effect in different conditions. Basically, there are A, B, C, with in relation of their interaction also with potassium. There are sodium channel block with also some potassium channel activity. Then there are the beta blockers that inactivate the channel, basically the calcium channel, the potassium channel blockers, mainly amiodarone and also sotalol, and the real channel blockers, verapamil and diltiazem. This picture is summarized in a very, I think, intuitive way where these different drugs interact. So basically the class 1 drugs interact with sodium, so they modify the upstroke of the action potential, and the class 3 drugs, or whatever drugs which interfere with the outward potassium currents, have an effect on the repolarization and later phase of the action potential. This really gives you the image on how the electrocardiogram is modified by this. So basically, drugs affecting the potassium will really modify the latest component of the electrocardiogram, reflecting this delayed repolarization in the action potential. And sodium channel blockers are going to modify the QRS, prolong the QRS basically, and in effect the morphology of the QRS and prolonging it. This is a view of this entire complex situation given by the Sicilian Gambit antiarrhythmic classification. This was proposed to overcome the problem of the classes, really giving you, I think, a very interesting idea to show the direct effect on the channel. And as you see, amiodarone, like the king of the antiarrhythmic drugs, the old king of the antiarrhythmic drugs, is really blocking basically all channels. And in fact, if you see, I will show you later the electrocardiogram equivalent of the amiodarone therapy, it's really clear that it affects everything, including, in fact, even heart rate in itself. While, for example, as I was saying before, a drug like quinidine, of course, is a sodium blocker, but it does also affect moderately, I would say, the potassium channel, and this is why it prolongs, typically prolongs QT interval. And instead, flecainide and also ijumalin are blockers of the slow channel, and this is why they are so specially active, we will see in Brugada syndrome. This is an example of what happened with the quinidine. You see how the electrocardiogram is deformed. You see a very late component of the QT, like almost you can say a U wave. And from this wave, a beat arises, and then the typical torsade point come up. Again, this is a woman, middle-aged woman. And this is even more, you see a clear image of this is a normal tracing, and the same tracing with quinidine, how you see how it is prolonged. But this is also a rate-dependent effect. So you see this effect much more at a longer QT interval. The QT interval is definitely more prolonged at faster heart rate than at a slower fast rate. You see, this is the baseline. This is what you see at 700 milliseconds, and what is instead at around 60 beats per minute. So that you see most of the effect at a faster heart rate. And why this is so? This you can also see by the Holter monitoring, this differential effect on the QT duration by heart rate. And this is mainly due to this so-called use-dependent effect. What is a use-dependent effect? It's an effect which is more evident during tachycardia. In this case, the IKR block is more evident during tachycardia, and this is why quinidine is like more toxic in correspondence of fast heart rate. But this is not only, I mean, this is the effect we can see on the cellular level on quinidine, how it behaves. But this is not only true for quinidine, it's also true for other drugs, like, for example, erythromycin, which is an antibiotic, which in a particular subject can behave in a way that is similar to quinidine, creating again arrhythmias with, unexpected arrhythmias. And what happens if you give these kind of compounds to patients which already have like a reduced potassium reserve. For example, this is a patient with a Barrett syndrome. It could be a Gittelman syndrome. So some renal disease by which the subject, the patient is really frequently in a hypokalemia. And so this is what happens if you give a drug, a possible toxic drugs to a patient with this kind of condition. And also the same condition of hypokalemia could happen in concomitance with the heavy administration of diuretics. So you can see why it's so easy to induce this kind of conditions. And I was saying before about amiodarone. So you see amiodarone being an extensive blocker, so really blocks the conduction. You see how this patient with normal QT at baseline, already some kind of intraconduction disturbance. You see how it is augmented during amiodarone therapy, how the amplitude of the T wave is reduced after amiodarone beside the QT prolongation. So that's a really general effect on the electrocardiogram. And so this is showing how this is modified according to heart rate. So the effect is more evident at a longer cycle length, but it's also evident that the amiodarone per se is also reducing cycle length, so is inducing bradycardia. So, but then if you really insist, you obtain this kind of arrhythmia in a patient who have never had arrhythmias before. So it's not a torsade point, it's like a slow tachycardia. So you have to be aware of this, because in like older patients on amiodarone, you might start to observe this kind of condition, which is still proarrhythmic, not the typical well-known proarrhythmia that you know with quinidine and torsade point. So there is a proarrhythmic effect. This patient taken out of amiodarone never developed arrhythmia, this kind of arrhythmia again. You see, many drugs modified their pattern after this kind of drugs. And so this is just to summarize where different drugs can act on the channel. So sotalol is clearly an IKR blocker, and quinidine is, as I said, is ITO and IKR blockers, and isoproterenol and other drugs may be calcium and potassium channel. As I say, I mean, basically you have main drugs that cause alteration, I mean, interact with the potassium channels that are more likely than others to induce proarrhythmias. As I said, there is also the possibility of a genetic background, which could be in the wild type, I mean, gone unknown until when you introduce a stress test like the administration of such drugs. Then there is a female gender, which is a known predisposition, as I said, electrolyte abnormalities, concomitant multi-therapy, and then the presence of pauses induced by AF, which is a potential important cofactor, or the presence of AB blocks, or VPBs or also PVCs and sinus arrhythmia. This is just to show that the weight of this is different for 1C and 1,3 and 1A and 3 antiarrhythmic drugs, as I showed you before in some examples. So when you administer 1C antiarrhythmic drugs such as flecainide or propafenone, you must pay really attention to the problem of the widened QRS, the presence of a structural heart disease, or the hallmark is going to be a QRS widening, or even worse, the appearance of a Brugada pattern, and we will go to that later. For the 3 class 1A and 3 antiarrhythmic drugs, the presence of longer, somewhat high-level QT interval at baseline that might suggest a possibility of some genetic predisposition, the presence of structural heart disease, bradycardia, as I said, high dose, interaction with other drugs, particularly diuretics and electrolyte deficiency. As I said, there is this aspect of the female gender. While the female gender is so much more involved in proarrhythmic effect, there are few explanations on that, and not really so much convincing yet, because it's not really so well understood, though this is such a widespread observation. The estrogen have effect on IKR and on their density. And it seems that the sex hormone prolong by themselves the QT interval by direct effect and downregulate by downregulating potassium channel expression. This is at least true in the rabbit heart. The fact that female gender have a longer QT interval, this is a general, well-known observation. I mean, in normal subject after puberty is well demonstrated in a variety of studies. So this is another direct proof of the effect of steroids on action potential duration on papillary muscle. So the effect is very, very likely to be due to estrogen, to gonadal steroids, although, I mean, it is still present in menopausal women. So it's more complex than that. As I said, there is the possibility of a genetic predisposition. The culprit gene basically are SN5A and HERG gene, which is a KCNQ2 gene nowadays. I mean, HERG is in general mammals, I would say, and is also known as with the in human with the name of KCNQ2. You will see that later. And these are genes implicated in the long QT syndrome. There are, as you know, there are three diseases collected under the name long QT syndrome because they really behave differently. They have different phenotypic expression, different also triggering factor, different therapies. So, I mean, it is nowadays we understand this much better than at the very beginning of the story. Anyway, the main mutation that really make almost 90% of all the patients with the long QT interval long QT syndrome are the KCNQ1 mutation, which is a sodium mutation, the QCN, it's potassium mutation, I'm sorry, the KCNQ2 or HERG mutation, again, having to do with the IKR, as I showed you before, and this is the SN5A mutation, which is a sodium mutation, which is also responsible for the Brugada syndrome in other portion of the genes. They behave differently in terms of heart rate relation, and it is interesting to say that they behave differently also in terms of how they respond to drugs. This is like a counteractive effect. It's not a proarrhythmic effect. It's a favorable effect, but a gene-based effect, which is the effect of mexiletine, which is a pure sodium blockers in a patient with LQT3, which has a sodium channel mutation. So if you administered mexiletine in a patient with SCN5A mutation, you have a very clear direct effect, rapid effect on the QT duration by mexiletine. And this is true for this patient as well. And interestingly, in this patient, we have also the Holter recording. You see that is completely abolished. The longer portion of the QT interval are no longer present. The heart rate QT relation is definitely changed by the acute oral administration of mexiletine. Now, to go from this to say that mexiletine is the definite cure treatment for LQT3 is still to be demonstrated, but it's clearly very interesting as a possibility. Oops. Oops. Why? I'm sorry. As I say, if you administer thioridazine, which is a non-cardiac drug, to a patient with slightly prolonged, almost normal female, you can have this kind of effect. You clearly induce a modification. Then this patient has been tested and discovered to be a carrier of this kind of mutation. So, of course, you would not have suspected her on the basis of the basis of her electrocardiogram at baseline, but after the stress test with thioridazine, we did the genetic testing and we discovered that indeed she was carrier of that mutation. And what about the Brugada syndrome? As I said, this is mainly associated with SN5A and also with other like a calcium channel. And these are the typical electrocardiographic appearance. But in case of Brugada, so this is type 1, very prominent, clear-cut diagnosis, but there are very subtle abnormalities that sometimes are observed. So in this case, it is interesting that the drug in itself, the possible proarrhythmic effect of the drug, it is utilized to make the diagnosis. So this is a patient with spontaneous type 1. If you give ismaline, you enhance the phenotype, but it's not very changed. But then if you give the drug to a type T2, or even to a patient with a almost normal type 3, but which is basically very, very normal tracing, in providing ismaline to a patient, these are patients that then have been discovered as NCN5A carriers, mutation carrier, it is clear that ismaline, it is able to induce a very typical type 1 Brugada pattern and give the possibility to, is a diagnostic test in this case. But you can be less lucky and administer flecainide to a patient that you don't know have such a predisposition. And this is what happened to us. Of course, it's not evident, but it's clearly there that you have, this is a Holter, it's implantable loop recorder, but this was also demonstrated on the tracing of this patient that had developed a typical Brugada pattern during therapy with flecainide given for paroxysmal atrial fibrillation and having this kind of arrhythmia. So this is not so rare, unfortunately, and that has always to be kept in mind when you administer flecainide that can have a pro-Brugada effect, determining proarrhythmias. So in essence, the proarrhythmic effect can be seen by sodium and potassium channel. The proarrhythmia is probably related to use-dependent property. So you see more extensive block at fast heart rate, but it's not always the case. This particularly with blockers like Amiodarone, which have a very general effect on all the channel. And so you have to be aware of the prolongation of the QRS and also of the QT. And this may lead you to verify some genetic predisposition. So far, it is mainly in most of the cases is like the genetic predisposition is discovered after you have a proarrhythmic effect and you do your analysis. In the future, you probably do the other way around. So I hope it was clear enough, and I will be very happy to, of course, have all your questions. Thank you for your attention.
Thank you, Emanuele, for this very nice review. Now the paper is open for comments and discussion. To warm up, I have a question about drug-induced bradycardia, Emanuele. Can we call drug-induced bradycardia, which didn't initiate ventricular arrhythmia, as a proarrhythmia?
Well, the problem is that about bradycardia, I mean, is there is this is a dynamic effect. So of course, I mean, it's drug-induced bradycardia, but these patients are still can still have all the possible sympathomimetic effect. They can have arrhythmia, which derange the sequence, creating short sequence. I remember I studied this when I was still at with Philippe Coumel at that time. No, that it was very interesting that even a premature supraventricular premature beat was able to induce the cascade of effect leading to the arrhythmias. And also atrial fibrillation per se, determining this wide range of heart rate, behave almost like a natural, I would say like a natural electrical test, because you have a short cycle following a long cycle, and so the having on board also drugs, and I said low potassium, etc., you reduce your repolarizing reserve, and this open like the field to the possibility to have after depolarization and the origin of an arrhythmias that becomes torsade de pointe that can end but cannot end. I mean, you never know what happened once you set the stage for torsade de pointe. So this is why I see this bradycardia tachycardia interaction. So you have to be quite I am very fond of this subject, so I could speak for hours. I could show you, I don't know how many tracing, like, I mean, you go into very complex area of cardiac memory of the repolarization. The repolarization does not adapt beat by beat immediately. There is also sometimes some lagging. So you can be in a few beats like lagging behind the heart rate changes. So it's a very complex and dynamic, and when you interfere to this complex field with gene burden, potassium, low level of potassium, or maybe even ionic derangement, and drugs, multiple drugs, we don't know what we give. And of course, as I said, also not only drugs, but also like alcohol, I mean, heavy meal. We know that this all interferes with the metabolic burden of the cell. So quite important.
Thanks so much. Any other question or comment? I cannot see anything in the chat box or question and answer box. While waiting for Emanuele, there is one question left for Andreas. The question is from Turkey, from my clinic. So I want to hear your comments about this. Andreas, where was it? Yes. In OT Pvgs, do you always map both RVOT and LVOT, even you have very good signal in RVOT?
No, not always. If I have a very early, and a near field signal in the right ventricular outflow tract, usually I ablate there. If activation is, more than 30 milliseconds ahead of the QRS, and the electrogram is nice, and the unipolar electrogram is also good, so it shows a QS. I usually burn there, and we don't have to map always the left ventricular outflow tract. If the activation is less early and or it's more diffuse, or if the unipolar signal is not as good, we prefer to map both sides.
Thank you, Andres. Yes, Peter, we have no more questions, no more comments. So please take the microphone.
I take the mic. Well, it remained for me then to thank Emanuela for a fascinating talk. So many drugs which seem to prolong the QT interval. I just wonder why half the world's population isn't wandering around with significant cardiac arrhythmias. Really an amazing list of drugs there. So thank you very much indeed on that very interesting review. And so let me thank everybody for participating, both speakers, and we look forward to seeing you again at the third ISE webinar. Thanks very much.
Thank you all.
Thank you.
Pleasure. Ciao.
Bye-bye.
Ciao, bye-bye.
Right on time, 3 o'clock.
Perfect.
It was a pleasure. Thank you very
Thank you.
Thank you,
really
Manuela.
nice.